As a neuroradiologist at the University of Wisconsin, I'm confronted with unknown intracranial masses every day in clinical practice. And I have to create a reasonable differential diagnosis, which is informed by the patient's clinical history, location of the lesion, and imaging features. That's the goal of my talk today. I have two primary objectives. By the end, I'm hoping that you're going to be able to generate a differential diagnosis for an intracranial mass based on anatomic location and the imaging features, and hopefully to recognize some common tumor mimics. Our first patient is a 50-year-old who's coming in with first-time seizure, facial asymmetry, and we're asked to rule out a stroke. So the patient starts off their imaging evaluation with a non-contrast head CT, and on this non-contrast head CT, no acute abnormality was identified. There was no hemorrhage and no evidence of cytotoxic edema. The patient went on to have an MR, and we can see on this T2 weighted sequence that there's quite a bit of T2 signal hyperintensity with some expansion of the brain parenchyma that involves lateral temporal lobe as well as the medial temporal lobe. There was no appreciable enhancement within this region of signal abnormality. So our first question is, why is this lesion not a stroke? Well, when we take a look at our diffusion-weighted sequence, we can see that there is a little bit of diffusion restriction, but that corresponds just to the hippocampus. The entire region is not diffusion restricting. So this hippocampal diffusion restriction is actually likely related to the seizure activity itself. Why is this not a stroke? Well, it doesn't really quite fit within a vascular territory. We can see here that the MCA territory involves much of the anterior lateral aspect of the temporal lobe, and it does touch on some of that medial component, and the medial aspect of the temporal lobe is really supplied by the PCA. And so we've got an area of abnormality that really spans two vascular territories. It doesn't really quite fit with vascular occlusion. So when we're thinking about a differential diagnosis then, if we're not thinking about stroke, of course we're going to want to be thinking about infection. And especially if you've got an area of abnormality involving the temporal lobe in a patient presenting with seizure, our top thing on our differential really should be herpes encephalitis. In this case is an example of herpes encephalitis with a classic distribution. We can see that it involves that medial temporal lobe. Herpes can also involve the insula, and in some patients you'll actually see it also involving the cingulate gyrus, which is not involved in this individual. It can be associated with some hemorrhage as well as some enhancement, and it can also be bilateral. The way to really diagnose herpes encephalitis is really by doing CSF and identifying herpes encephalitis based on PCR. Our next entity on our differential diagnosis for lesions involving the temporal lobe is going to be limbic encephalitis. And limbic encephalitis can really have overlapping imaging features with herpes encephalitis. We can see in this example that there is some involvement of that medial temporal lobe. It looks like there's some gyral expansion. Limbic encephalitis doesn't typically involve the insula or that cingulate gyrus, and it certainly can involve other areas of the brain as well. Similar to herpes encephalitis, we will often do CSF analysis and do some additional testing. These patients may have some additional reasons why they might have limbic encephalitis related to tumors elsewhere in the body. Tumors can also involve the temporal lobe. This is a characteristic one where you can see you've got this soap bubble appearance of this lesion. It doesn't really look anything like our index case, but this is kind of a classic Aunt Minnie diagnosis with that soap bubble appearance. This is characteristic of a tumor called a DNET tumor. You can also have gangliogliomas involve the temporal lobe, and characteristically they're going to have a cyst with an enhancing mural nodule, as we see in this example. So this patient actually was treated for herpes encephalitis, even though the PCR was negative, which is kind of unusual to continue on with that diagnosis with PCR negative disease. The patient ultimately was discharged and presented 1 year later. And we can see on this MR, we've got quite a different lesion where you have this area of heterogeneous enhancement involve the temporal lobe, and this ultimately was a grade 4 astrocytoma. At initial diagnosis, this was potentially a lower grade tumor. We don't have any areas of enhancement, so potentially a grade 3 at the time of diagnosis that then potentially just dedifferentiated into a higher grade lesion. So when we're considering our differential diagnosis based on imaging, our first question is really, where is the tumor located? Is it in the brain parenchyma or outside the brain parenchyma? If it's outside, we're going to characterize that as extraaxial, and if it's inside the brain parenchyma or arising from the brain tissue, we're going to characterize that as intraaxial. If it's extraaxial, 9 times out of 10, you're going to be favoring a diagnosis of meningioma. Those typically are going to involve the dura, and ultimately these lesions can be really anywhere involving the dura. If you have the tumors that are extraaxial, that are centered around cranial nerves or the internal auditory canal or within the posterior fossa, you might want to consider schwannoma, maybe higher on that differential. Dural-based metastasis, parenchymal tumors with dural extension can also occur, but they're just a lot less common, I should say. Intraaxial tumors you're going to divide that into primary tumors versus metastatic. Primary tumors are really considered based on their cell of origin. Are they arising from one of the support cells, i.e. glial tumors or neuronal tumors, or is it potentially metastatic coming from somewhere else or a tumor mimic? So our intracranial masses, is it tumor or not? And if it's a tumor, we have to be thinking about, is it a primary or metastatic disease? If it's primary tumor, we're going to be thinking about tumors arising from neuroepithelial tissue, and that is divided into glial and non-glial, or support cells and our neuronal cells. The support cells are tumors that are arising from astrocytes, oligodendrocytes, and ependymal cells, and astrocytomas tend to be the most common of those glial cells. Ependymomas are the least common of that category. Our non-glial tumors are there's a broad list of those tumors. I've just identified a handful here. DNETs, gangliogliomas, and gangliocytomas are just much more rare. And then you have a whole host of other primary tumors that are kind of subcategorized based on location. So you can have tumors arising from the pituitary gland, pineal gland, etc. So our next patient is a 73-year-old who's coming in with headaches and nausea and vomiting. This is a patient who also has a tumor arising from the temporal lobe. This one looks quite a bit different at that initial diagnosis, where we can see here that we have a region of heterogeneous enhancement with a significant amount of vasogenic edema and mass effect. So this patient at presentation is coming in with a higher grade tumor. Based on that necrosis and heterogeneous enhancement, we're going to be favoring a high-grade glial neoplasm and astrocytoma. In a pathology, this was a IDH wild type, which is the aggressive type of astrocytomas. So this is designated as a glioblastoma based on that wild type feature, and this was also noted to be MGMT methylated. This is a 31-year-old who's coming in with a new onset tonic-clonic seizure, and this patient also has a lesion involving the temporal lobe. Notice how this patient's lesion looks quite a bit different than the first two cases. We can see here that this patient's lesion is well circumscribed, and there's not really much in the way of mass effect or vasogenic edema. There is enhancement, though, on our post-contrast image, and there's some parts of the tumor that are not enhancing. So based on this well-circumscribed appearance of this tumor, kind of looks like a cyst with an enhancing nodule, we're going to be thinking about one of the well-circumscribed tumors, and with a cyst with an enhancing nodule, you're going to be favoring a diagnosis of a pilocytic astrocytoma. Could this be a ganglioglioma? Potentially, and at pathology, this was a pilocytic astrocytoma, which is a grade 1 tumor. This patient also has a lesion of the temporal lobe, a companion case, a 30-year-old who's coming in with headaches and tinnitus. This patient's lesion is quite a bit bigger than the last case. The component of enhancement is much larger. There are some areas of non-enhancement. And then when we take a look at our T2-weighted sequence, we can notice here that there's a cleft of high signal kind of surrounding the lesion, and this lesion has kind of a thicker capsule. Now, the clue to this diagnosis is really to recognize the location of this lesion. So on the axial images, it really looks like it's intraaxial. However, when you take a look at the coronal images, you can see here that this mass is not surrounded by brain tissue on all sides. Looking at the inferior border here, you can see that this lesion has quite a bit of a broad kind of attachment or abutment, I should say, with the extraaxial kind of space. And so this is really important to recognize that this tumor is not actually intraaxial, even though on the axial images it kind of looks like it is, and to recognize that there's a CSF cleft actually separating the tumor from its adjacent temporal lobe, which is ultimately kind of pushing up from below, causing quite a bit of mass effect. Notice here how there is some enhancement that's extending kind of below the tumor involving the skull base. So clue to this case actually is looking at the skull base involvement. Notice here how this mass actually extends along the anterior genu of the facial nerve. You can see that there's some enhancement that's involving that labyrinthine segment, as well as this broad attachment with that kind of anterior and tympanic segment and geniculate segment. So we're going to be thinking about meningioma or potentially schwannoma in this case, and this turned out to be a schwannoma arising from the facial nerve. So clue to this case is recognizing the skull base involvement. So you want to, of course, take a look at your axial images, but pay attention to the coronal images as well to see and confirm that the tumor is actually surrounded by brain tissue on all sides. If it's not, you really want to be thinking about alternative diagnoses, and meningioma and schwannoma are the things that you want to be considering. Look for that nerve involvement. Nerve involvement can certainly actually occur with meningiomas, but you definitely want to be thinking about a schwannoma, particularly in this example. Okay, let's move on to posterior fossa. So this is a 6-year-old who's coming in with 6 weeks of headache and ataxia. And we can see here that this patient's got a mass that's centered within the left cerebellum. When we take a look at our sagittal image, we can see that there's some inferior cerebellar tonsillar herniation. And when we took a look at the characteristics of the lesion itself, we can see that there's an enhancing component anteriorly and a non-enhancing portion, cystic portion, noted posteriorly. The clue to this case is actually recognizing that there are globoids kind of adjacent to this dominant mass. Lesion is certainly causing some mass effect on the fourth ventricle and resulting in some obstructive hydrocephalus with transependymal flow of CSF. So what's our differential diagnosis for lesions in the posterior fossa? Well, it's actually kind of rare to have a primary tumor arising from the brain tissue itself. It's actually just much more common to see metastatic disease. So these next two cases on our differential list are metastatic breast cancer and metastatic esophageal cancer. Metastatic disease can look like a lot of different things. They can be predominantly rim enhancing, they can be solidly enhancing, there could be multiple, there could be singular lesions. This next case, it looks a little different than our first three examples here. This is kind of an Aunt Minnie diagnosis. On our T2-weighted sequence, we can see that this lesion kind of has a tiger stripe kind of appearance here. I'm not showing you any post-contrast images, but there's not really much enhancement of this particular lesion. This lesion with that tiger striped or tigroid appearance, this is characteristic of Lermite-Clos or dysplastic cerebellar gangliocytoma. This is a lesion that is kind of a hamartomatous lesion that can be seen in the setting of Cowden syndrome. Our next case is a solidly enhancing mass that kind of looks almost like a marshmallow or a fluffy cloud. We can see that there is this area of what looks like leptomeningeal enhancement adjacent to the dominant mass, and this is an example of lymphoma. So lymphoma tends to have kind of a well-circumscribed margins, and they will often have this fluffy cloud kind of appearance. So the clue to this case is recognizing the vascular flovoids associated with this lesion. This case is not represented in our differential list, but is an example of a hemangioblastoma. Hemangioblastomas are the most common primary tumors that are arising from the posterior fossa in an adult. They can be sporadic, but they can also be associated with von Hippel-Lindau syndrome. So it's important to consider VHL on the differential diagnosis in a patient with a hemangioblastoma, or especially if you're considering one, and take a look for other examples of hemangioblastomas within the upper cervical spinal cord that you potentially can get a glimpse of, and then looking for lesions within the posterior fossa. An endolymphatic sac tumor, you might be able to pick up on enlargement of the vestibular aqueduct in these individuals, so take a look for those additional clues. A companion case in the posterior fossa, this is a 6-year-old who's coming in with 1 week of headaches, difficulty walking, and right-sided weakness. We can see that this patient has an obvious abnormality within the right cerebellum, and it looks kind of cystic, particularly on the CT examination. On MR, we can see that the lesion has this gracile, kind of very thin rim of enhancement around the periphery. That rim of enhancement also demonstrates some diffusion restriction just along that solidly enhancing part of the mass. And we can see that there's a small adjacent kind of daughter lesion just adjacent to the dominant mass. So we're going to be thinking about multiple lesions in the posterior fossa. You can certainly think about hemangioblastoma, but we don't really have any flovoids here. And because of the multiple lesions, we're going to be considering alternate diagnoses and metastatic disease is going to rise to the top, particularly for a rim-enhancing mass in an adult with multiple lesions. So when we're thinking about metastatic disease, our next step is really to try to figure out where's the primary tumor. And oftentimes it might be the radiologist suggesting this diagnosis. The patient may be presenting actually with their metastatic disease, so you kind of have to work your way backwards. So when you see a mass potentially within the posterior fossa or multiple lesions, you're going to be wanting to recommend some additional testing. So the next step is often going to be doing a chest, abdomen, and pelvis CT, looking for primary tumors, looking for lung cancer, maybe breast cancer, skin cancer or melanoma, colon cancer, and renal cell. Those are kind of the top 5 tumors that have a predilection to metastasis. This patient ultimately ends up getting a chest CT. We can see upon a background of really diffuse emphysema, we've got this large spiculated mass within the left lower lobe, and this patient happened to present with their metastatic lung cancer to their posterior fossa. Anytime a patient is being evaluated for metastatic disease, you want to look for some corner shots, so look for some additional clues that might be helpful in terms of identifying the full extent of the tumor. It's important to look at the skull base as well as the upper cervical spine. So pay attention to your sagittal T1s, not just at the midline, but going off midline. Okay. We can see at the midline, the clivus should have this normal marrow, same with the upper cervical spine. Then we can see off midline that marrow has been replaced by this metastatic lesion. I really like to take a look at the diffusion. The diffusion can be quite helpful at picking up lesions within the skull base. You can see in this example how the lesion is kind of off midline, maybe indicating that we should be kind of paying attention to that area. Also, you might be able to see corner shots within the neck. We have 2 sequences that we kind of get a little lower than the skull base, so we can see this kind of tip of the iceberg lesion where you've got this enhancing node within the right level 2 region, right level 5A region on this PET scan, where we've got this hypermetabolic lymph node here. So pay attention to those sequences, particularly that go into the neck. You may be able to appreciate some metastatic adenopathy. Let's move on to the corpus callosum. So this is a 44-year-old who's coming in with headaches, and we can identify we've got MR, the 2 left images, and CT on the right. The lesion looks quite aggressive. It is involving that left frontal lobe, but it's crossing that anterior genu of the corpus callosum and in really involving both frontal lobes, left greater than right. T2 looks really pretty heterogeneous. You've got some areas that are necrotic, some edema, some areas that are brighter than others. And when we take a look at our post-contrast images, I'm kind of struck by the fact that there's actually not as much enhancement as I would expect. We certainly see enhancement, but based on what it's looking like on the T2, I would kind of expect it to maybe have a lot more heterogeneous enhancement. And I think that the clue to this case is actually really recognizing all of the dystrophic calcification associated with this lesion. So let's take a look at our differential diagnosis slide. So we've got our index case here, and we want to be thinking about tumors and tumor mimics. So tumors can really come in a lot of different varieties, particularly involving the corpus callosum. Here we have a non-enhancing tumor. We can see the post-contrast images, no enhancement, but we've got this quite a bit of expansion of the corpus callosum, quite a bit of mass effect. This was a grade 2 astrocytoma, and that expansion is really pushing us towards a tumor diagnosis, and we can see that cortical involvement with cortical thickening. This tumor has much more necrosis, where you've got heterogeneous enhancement, enhancing and non-enhancing components with some kind of high cellularity here. This is kind of a classic butterfly glioma that you'll see in the setting of GBM. This tumor here, I'm just showing you kind of 2 characteristic sequences that are really helpful in making the diagnosis of lymphoma, where we've got diffusion restriction, and on CT you can see this hyperdense mass involving that posterior genu of the corpus callosum. This is an example of lymphoma. You would also expect to see enhancement of this lesion on our post-contrast images. You can also have pilocytic astrocytomas, as we saw in that example in the temporal lobe. This just happens to be a pilocytic astrocytoma, cyst with an enhancing nodule, just in the corpus callosum. So pilocytic astrocytomas can occur really anywhere. We commonly think about them as a pediatric type tumor within the posterior fossa. This just happens to be a common tumor, but just in an unusual location. And then this next example here, you can see you've got multiple lesions that are really centered in the white matter, and you've got a lesion involving the corpus callosum, that body of the corpus callosum. This is an example of demyelination. So our index case was an oligodendroglioma. Could have predicted that just based on the dystrophic calcification. Calcification happens to be kind of a hallmark feature of oligodendrogliomas. And classically, oligodendrogliomas, epithology, they're going to have this 1p19q co-deletion. That's really how oligodendrogliomas are classified, and they are subcategorized as grade 2 and grade 3. There's not as much enhancement, honestly, that we'll see with oligodendrogliomas. And so if you have what looks kind of like an aggressive tumor, but not much enhancement with calcification, you're going to favor oligodendrogliomas over astrocytoma. These next two tumors, two different additional patients, these are a little bit more nondescript in that you've got what looks like, flare signal hyperintensity with some expansion, bilateral frontal lobe tumors, and this could easily have been an astrocytoma. Likewise, this what looks like a cyst with an enhancing nodule in this individual who actually presented with seizures, this could have easily have been a pilocytic astrocytoma. So these are a little bit more nonspecific, but this diagnosis here, I think you could kind of favor that diagnosis based on the features that we've already discussed. Companion case is a 68-year-old who's coming in with confusion and headaches. This patient ended up getting a pre- and post-contrast head CT, and we can see what we've got an area of kind of enhancement involving that splenium of the corpus callosum with quite a bit of vasogenic edema adjacent to it. Based on this, we're really going to be thinking about kind of three diagnoses. We're going to be thinking about a GBM, that butterfly glioma that we've just talked about. We're going to be thinking about lymphoma and tumefactive demyelination. So those are kind of the three big things that we want to consider. The patient's going to get an MR, of course, and we can see on this MR examination how you've got an area of enhancement and diffusion restriction kind of corresponding to this. Our differential diagnosis is really going to still include those three things. We favored lymphoma in this case because of the diffusion restriction, and we're a little surprised to see at pathology that this actually turned out to be active demyelination. So it was just biopsied because we were favoring lymphoma, just a little more unusual to see active demyelination in a 68-year-old male. It just didn't quite fit the demographic for us. Okay, let's move on to ring-enhancing masses. So this is a patient who came in with gradual left-sided weakness. They got an MRI, and we can see on this MR how we've got this mass that's involving the kind of posterior frontal lobe in this perirolandic region. And notice here how the lesion has quite a bit of thickness along its medial edge. It is non-enhancing in the middle, and it's got this rim-enhancing periphery. So we've already seen some examples of rim-enhancing masses in the case discussions already. We saw a few ring-enhancing masses within the posterior fossa that turned out to be metastatic disease. We're going to certainly think about that on our differential here. But we're going to be looking for some additional clues on these images to try to help us try to figure out, is this metastatic disease or infection, or potentially could this be a primary tumor? So I think that the hallmark of this case is to recognize that there is not really much in the way of vasogenic edema surrounding this lesion. That was pretty characteristic of our metastatic lesions that we've seen. This case actually has quite a bit of non-enhancing T2 signal hyperintensity, really involving the cortex, that medial edge of the brain. And so that is really going to be helpful for us in terms of narrowing our differential. So let's think about our ring-enhancing differential diagnosis. We're going to be thinking about our rim-enhancing masses with some diffusion restriction around the periphery. This looks like kind of an aggressive, really thick rim of enhancement, and this is characteristic of a GBM. We've already seen this case here where we've got this kind of thin rim of enhancement. This patient had multiple lesions. This was metastatic lung cancer. Here we've got what looks like an aggressive lesion. The enhancing portions of the mass was actually extending across the corpus callosum because of that diffusion restriction, we might want to also consider lymphoma, and that's what this one turned out to be. Notice how in this example, how there's multiple ring-enhancing masses. We're going to be wanting to try to understand what their immune status is. If the patient's immunocompromised, we might want to think about toxoplasmosis. Looking at the diffusion, toxo actually ends up not having much in the way of diffusion restriction, which is how one can differentiate between lymphoma and toxo in the immunocompromised individual. In our next case on our differential list, we certainly are going to be wanting to think about infection. Now, this is the one example that I'm showing you that has diffusion restriction centered within the rim-enhancing mass. This is really characteristic of a pyogenic abscess. So any individual that has a rim-enhancing mass, you really want to pay attention to the diffusion sequences. If there's diffusion restriction in the middle of it, you're going to potentially be favoring infection, particularly if the patient has the clinical features that you should be thinking about infection. That is how really diffusion can be quite helpful. In this individual, we can see that this patient's got a rim-enhancing mass, but the enhancement really is discontiguous in terms of that ring. And with this discontiguous or C-shaped area of enhancement, you're going to be wanting to think about tumefactive demyelination. This patient also had diffusion restriction corresponding to the area of enhancement, and this turned out to be multiple sclerosis. So in our index case, with the gradual left-sided weakness, with that non-enhancing part of the disease process, so you've got this area of necrosis plus non-enhancing tissue that doesn't look like vasogenic edema. It looks like non-enhancing tumor next to enhancing tumor. You're going to be favoring an aggressive tumor, and this turned out to be a GBM. And it's really recognizing this non-enhancing tumor that's going to put GBM kind of higher on your differential. Let's take a look at our hyperdense masses. And so this is our first case in this category is a 25-year-old who's coming in with a headache. And we can see that the patient has a hematoma within their anterior temporal lobe. The patient ends up getting a post-contrast CT as a part of their workup, just trying to see is there any areas of enhancement, and maybe just a thin rim of enhancement around the periphery. But it's hard for us to know what's the underlying cause of this hematoma. You're going to certainly want to be thinking about a venous infarct, particularly with hematomas in the temporal lobe. So really pay attention to the draining dural venous sinus. So these are as a result of occlusion of the vena lobae that will empty into the transverse sinus. So pay attention to that transverse sinus. If there's hyperdensity along that, you could offer that as a potential option for hemorrhage within the temporal lobe. You can also certainly see lesions or hemorrhage associated with vascular malformations. Cavernomas are common. So one potential clue for cavernoma is potentially to recognize a developmental venous anomaly, maybe associated or adjacent to the cavernoma, and that could really help to sway you in the direction of vascular malformation as opposed to an alternate diagnosis like a tumor. Here in this example, you can see that there's a hyperdense mass associated with the brain parenchyma. It's kind of peripherally located, but quite a bit of vasogenic edema. This is not hemorrhage, but rather related to a hypercellular tumor that we'll typically see in the setting of lymphoma. And this patient is presenting with hemorrhage associated with an underlying tumor that turned out to be a hemorrhagic metastasis. So in this individual, really the next step is to do a brain MRI. And we really want to try to figure out, is there an underlying lesion associated with that hematoma? And oftentimes it can be hard to actually really assess, particularly in the acute setting. Trying to look for any additional areas of enhancement. The tough thing is that the hematoma itself can mask the underlying lesion. So there are certain types of tumors that have a predilection for hemorrhage, and that is melanoma, renal cell, thyroid carcinoma, choriocarcinoma, as well as lung cancer and breast cancer, just because they're so common. And this individual was ultimately diagnosed with metastatic melanoma. So relatively young individual, but presented with hemorrhagic metastasis related to metastatic melanoma. This individual is in their 60s who's coming in with headache and vision loss, and we can see that the patient is presenting with the hematoma within their left occipital lobe. The patient, of course, ends up getting an MRI, and we can see that there's kind of a thin rim of enhancement along the kind of periphery of this hematoma. So is that thin rim of enhancement related to just blood-brain barrier breakdown because of the hematoma, or is there an underlying mass there? It's hard to tell. So what's the next step? Are we going to send the patient to the OR for hematoma evacuation even though they're clinically stable, or are there some additional things that we could do? We can certainly look for, foci of metastatic disease, get a chest, abdomen, pelvis CT, but ultimately, oftentimes the next step is just to wait. And so to do a short-term interval follow-up, and that's really like another scan in 1 to 2 weeks. And so this patient ends up getting an MR, repeat MR 2 weeks later, and we can see that the enhancement is a lot more exuberant than the initial examination, and this turned out to be a GBM. So GBMs can also present with hemorrhage, as we can see in this case, in addition to metastatic disease. This next case is a 76-year-old who's coming in with seizure activity, and we can see on this head CT that we've got this area of hypercellularity. Doesn't quite look like it has the density that is going to match a hemorrhage, but there's something that's certainly right about this lesion. The patient gets an MR, and we can see on T2 that it's relatively dark. It's got this kind of well-circumscribed area of enhancement. The thing that's notable about this case is that there's quite a bit of diffusion restriction associated with this lesion. And because of that diffusion restriction with this solidly enhancing mass that has some leptomeningeal disease kind of adjacent to it, we're going to favor the diagnosis of lymphoma, and that's what this one turned out to be. Okay, our final case that is going to potentially pull it all together, we've got an individual who's presenting with seizures and left-sided weakness. So the patient has this large area of flare signal hyperintensity, T2 hyperintensity involving much of the temporal lobe. It's involving the medial temporal lobe, the insula, kind of marching its way up through the frontal and temporal opercula. This area doesn't really look like it is enhancing that much, but it looks like our initial case that we started off with. So could this be a non-enhancing tumor? It certainly has that gyral expansion. It doesn't really fit the bill for herpes encephalitis or limbic encephalitis. So this one lesion in and of itself kind of has some features that I'm going to be favoring. A tumor, potentially a grade 2 or grade 3 astrocytoma. But lo and behold, we have a couple of other areas of abnormal enhancement. We've got an area of enhancement that is involving that perirolandic kind of posterior frontal lobe, that precentral gyrus here. We've got this rim-enhancing lesion, as well as this other area of enhancement kind of involving the meninges. It's unusual for metastatic disease to involve, to cause this non-enhancing tissue. So how do we kind of put it all together? Well, this patient has multifocal glioma with this rim-enhancing component along the more aggressive kind of manifestations. We got some leptomeningeal disease, as well as this non-enhancing tumor. So this was multifocal GBM. So in summary, we have reviewed these 5 categories of tumor. We started off by taking a look at our temporal lobe differential diagnosis. We're really wanting to think about herpes encephalitis, particularly if you've got a patient presenting with first-time seizure, but you really want to consider alternate diagnoses, particularly if the PCR is negative. Even though patients presenting with seizures and clinical concern for herpes, if PCR is negative, think about tumor or other diagnoses. Posterior fossa masses, you're going to be thinking about metastatic disease, which is the most common intraaxial posterior fossa mass in an adult, but you want to think about hemangioblastoma, particularly if loboids are present. A couple of Aunt Minnie diagnoses in there as well. If you've got that tiger-striped appearance, you're going to be thinking about Laramie-Ticlot, as well as potentially lymphoma. Lesions involving the corpus callosum, you're going to be thinking about astrocytoma, oligodendroglioma, lymphoma, and demyelinating disease. That's kind of your trifecta of your differential diagnosis. You don't want to forget about demyelinating disease, particularly in the adult patient. Rim-enhancing masses, that's a really broad differential diagnosis, and it's really informed by the clinical presentation. So is the patient immunocompromised or not? Diffusion can really be quite helpful to differentiate pyogenic abscess from tumor. This is something that comes up every day in clinical practice. You really just want to be comfortable with this differential. And then hyperdense masses, you're going to be thinking about metastatic disease and GBMs. Both of those can present with hemorrhage. You also want to consider vascular lesions and potentially hemorrhagic venous infarct, potentially from occlusion of the vena pubae. You don't want to forget about lymphoma. Those are certainly going to be presenting as hyper hypercellular tumors, not necessarily with hemorrhage, but they are going to be bright on CT and have a characteristic diffusion restriction. Thank you so much for your time and attention, and I really hope that you enjoy the rest of the meeting.